Welcome to USMLE with Varun. Hi. So this is the third video of our psychiatry series. So in this video, we'll be discussing mood disorders, bipolar disorders, antidepressants, and suicide risk. Before beginning with the video, I would like to request everyone to please subscribe and keep supporting. This is an open access lecture series which is provided free. If you find it useful and wish to support it, link is in the description. You can click the link and pay with any of these pathways. So coming to the objectives, uh, by the end of this video, you'll be able to understand mood disorders clearly. You'll be able to differentiate between depression and bipolar disorders. We can uh, learn about antidepressants and mood stabilizers uh, and understand about side effects and emergencies. What are mood disorders? Mood disorders are conditions where the main problem is abnormal emotional state. So can affect like this includes persistent sadness or abnormally elevated mood. These disorders affect sleep, appetite, energy, thinking, and daily functioning. Mood disorders are built from four types of episodes like depressive episode, manic episode, hypomanic episode, and mixed episodes. How long it lasts and how severe it lasts decides the diagnosis. A major depressive episode means low mood or loss of interest for at least 2 weeks, along with several physical and mental symptoms that impair daily life. Major depressive disorder means one or more major depressive episodes with no history of mania or hypomania. If a patient has ever had mania, then the diagnosis is not depression, it becomes a bipolar disorder. Caps helps remember depression symptoms. So, S is sleep disturbance, loss of interest, guilt, low energy, poor concentration, appetite changes, psychomotor changes, suicidal thoughts. Five or more symptoms for 2 weeks are needed to diagnose depression. Dysthymia is a chronic low-grade depression lasting for at least 2 years. Symptoms are milder than major depression but are long-lasting. So the pattern in this case is that the patient is always sad but functioning and chronic. Chronicity is something that should be noted upon. Bipolar disorder involves episodes of depression and episodes of mania or hypomania. Identifying mania is crucial for diagnosis and treatment of a bipolar disorder. Mania is an abnormally elevated or irritable mood lasting at least 1 week or requiring hospitalization. It causes severe impairment and may include psychosis. Symptoms of mania can be memorized using the mnemonic dig fast. So DIGFAST stands for distractibility, irresponsible behavior, grandiosity, flight of ideas, increased activity or agitation, decreased need for sleep, and being doctor. Decreased need for sleep is the strongest exam clue for identifying mania. Hypomania has the same symptoms as mania, but it is less severe. It lasts for about at least 4 days. It does not require hospitalization. There is no psychosis. Functioning is impaired but is not destroyed. In other case, we can also tell that there is increased productivity in a patient with hypomania. Bipolar I disorder requires at least one manic episode. Depression may or may not occur. Bipolar II disorder requires at least one hypomanic episode and one major depressive episode with no history of full mania. So this bipolar II disorder is commonly misdiagnosed as depression. Cyclothymia is a chronic mood instability with mild hypomanic and mild depressive symptoms lasting for at least 2 years. The patients are emotionally unstable for years. Antidepressants are divided into SSRIs, SNRIs, TCAs, MAO inhibitors, atypical antidepressants. These are used mainly for MDDs, anxiety disorders, OCTs, and PTSDs. Key exam focus in these antidepressants, we need to understand the mechanism, we need to remember the side effects, and also we need to understand that they have a lot of drug interactions. SSRIs includes fluoxetine, sertralin, citalopram, escitalopram. They increase serotonin in the synaptic junctions and are first line because they are safer even in overdose and they're effective. So SSRIs are the first line antidepressants. Side effects of SSRIs includes nausea, diarrhea, sexual dysfunction, weight changes, insomnia or sedation, and early increase in suicidal thoughts in young patients. So whenever some patient is started with SSRIs in early phase, we need to take care. If the patient, particularly young patients, if there is any increase in suicidal thoughts, we need to take care about adjusting the dose of these SSRIs. SNRIs like venlafaxine and duloxetine increase serotonin and norepinephrine and can cause high blood pressure. And SNRIs also have similar side effects to SSRIs in addition to increased blood pressure. TCAs block serotonin and norepinephrine reuptake and can cause anticholinergic effects like dry mouth, blurred vision, urinary retention, and sedation. And TCAs, the most important side effect of TCAs is that it can cause fatal arrhythmias. It has uh, main toxic effect like cardiotoxicity, which should be taken care of. So it is very toxic in overdose. So amitriptyline, nortriptyline, whenever they're prescribed, you need to look out if there is any occurrence of arrhythmias. We need to carefully monitor for arrhythmias. MAO inhibitors prevent breakdown of monoamines like serotonin, norepinephrine, and dopamine. Examples of MAO inhibitors includes phenelzine and trancyclopramine. Uh, There is a possibility that it can cause hypertensive crisis when MAO inhibitors are taken along with tyramine-rich foods like cheese and wine. And MAO inhibitors also have severe drug interactions with SSRIs and TCAs. So these are used rarely due to safety issues and drug interactions. Atypical antidepressants includes bupropion, mirtazapine, and trazodone. Bupropion causes seizures at high dose. Mirtazapine causes weight gain and trazodone causes sedation. So this trazodone is mainly used for sleep. So trazodone is an atypical antidepressant which is mainly used for sleep induction. So and maintenance. Antidepressants in bipolar disorders. Uh, Antidepressants alone, when given in patients with bipolar disorders, they trigger mania and worsen bipolar disorder. So if the patient is diagnosed with bipolar disorder, always add a mood stabilizer in addition to the antidepressant. Mood stabilizers includes lithium, valproate, carbamazepine, and lamotrigine. These are used for bipolar disorder and prevention of mania and depression. Lithium is the most important mood stabilizer and reduces suicide risk, but it has a narrow therapeutic window. Lithium is the most important mood stabilizer, but one thing that limits its use is that it has a narrow therapeutic window. Common side effects includes tremor, weight gain, increased urination, and hypothyroidism. In a patient who is started with lithium, we need to monitor serum lithium level, kidney function, and thyroid function regularly. We need to look for signs of lithium toxicity like severe tremor, ataxia, confusion, vomiting, diarrhea, and seizures. One thing we have to definitely remember when giving lithium is that dehydration or NSAIDs, when given along with lithium, can cause lithium toxicity, so it should be taken care of. Valproate treats mania, but it causes hepatotoxicity, weight gain, pancreatitis, and most importantly, neural tube defects. So this valproate is is and should be avoided in pregnant women. So most important side effects of valproate includes hepatotoxicity and neural tube defects. So this should be taken care of. Carbamazepine can cause agranulocytosis, aplastic anemia, and also many drug interactions. So Exam clue in case of a question involving carbamazepine is that there may be low WBCs, there may be presence of rash, and there also might be mentioning of mood stabilizer usage. Lamotrigine can cause Steven-Johnson syndrome, which is a life-threatening skin rash. Whenever you see something like a rash and mucosal ulcers in patients who are started with lamotrigine, you have to understand that he is at a risk of developing Stevens-Johnson syndrome. Serotonin syndrome is a life-threatening condition due to excess serotonin, often from drug combinations like SSRIs, MAO inhibitors, SSRIs, TCAs, SSRIs, tramadol, linezolid. So the onset of serotonin syndrome is in hours. Key clinical features of serotonin syndrome includes high fever, agitation, diarrhea, sweating, tremor, hyperreflexia, and clonus and dilated pupils. So whenever you see something like hyperreflexia and clonus, you need to start thinking about possibility of serotonin syndrome. Serotonin syndrome has fast onset and hyperreflexia. Neuroleptic malignant syndrome has slow onset and muscle rigidity. This has hyperreflexia, whereas NMS has muscle rigidity. Serotonin syndrome has fast onset, whereas NMS has slow onset. Okay, so the cause of serotonin syndrome includes SSRIs, MAO inhibitors, and TCS, whereas the cause of NMS is antidepressants and antipsychotics. Uh, Pupils are dilated in patients with serotonin syndrome, whereas pupils are normal in patients with neuroleptic malignant syndrome. Vowel sounds are increased in patients with serotonin syndrome, whereas vowel sounds are normal in patients with neuroleptic malignant syndrome. So, suicide risk factors includes depression, bipolar disorder, substance use, previous attempts, male sex, elderly age, and chronic medical illnesses and social isolation. So, whenever previous attempt is mentioned in the question, it is the strongest predictor for future suicidal risk. Warning signs of suicide includes giving away possessions, writing goodbye notes, saying life is meaningless and there is hopelessness, and sudden calmness after depression. So all these are warning signs of suicide. If someone talks about death, you need to understand that it's a warning sign. So whenever there is sudden improvement after depression, so it is a really, really dangerous sign and it indicates suicidal intent in a patient. Management of a suicidal patient is that we need to ask directly, assess plan and intent, hospitalize if there is high risk, remove means, and treat underlying disorder and illness. And also we need to close follow. So whenever we suspect a suicidal intent in a patient, safety comes before diagnosis. We need to act first and then diagnose later. So psychiatric questions are mostly dependent on pattern recognition. So now we'll be discussing few pattern recognitions that can help us understand how questions are framed in USMLE. So there's a 25-year-old woman. There is low mood for 3 weeks, loss of interest, poor sleep, fatigue, no history of high energy. There is no history of manic episode. So all these outlines to a diagnosis of a major depressive disorder. The key clues includes duration greater than or equal to 2 weeks, symptoms that are often seen from these major symptoms, and there is no mania. Whenever there is no mania, you can outline to a diagnosis of major depressive disorder. Coming to case two, there is decreased sleep, there is grandiosity, there is risky behavior, and aggressive behavior with excessive talking. All these uh, makes us think about manic episode. So there is a manic episode going on. So whenever there is manic episode, you need to think about bipolar I disorder. So the key clue in this question is decrease in need for sleep and risky behavior, grandiosity. Case 3. So patient with depression is started on SSRIs. After 1 week, the patient develops high energy, fast speech, irritability, and no sleep. So all these are symptoms of mania. So the patient is started on antidepressant alone. So it triggered manic episode. So whenever there's a patient who is having underlying bipolar disorder, when they are prescribed antidepressant alone, it can cause and trigger mania. So we need to take care that we also need to add a mood stabilizer in addition to the antidepressant. Coming to case 4, there is tremor, confusion, and vomiting in a patient who's started with lithium. So we need to think about lithium toxicity. The exam clue is that there is recent dehydration or NSAID use. Case 5, there is painful rash and ulcers after lamotrigine is started. So we need to think about Stevens-Johnson syndrome, painful rash, and mouth ulcers. The most important features. Action is that we need to stop the drug immediately. Now we'll also discuss few questions. So a 28-year-old woman, low mood for 8 months, poor sleep, low energy, poor concentration, no history of high energy episodes. So all these, low mood, flat affect, poor sleep, sleep disturbance, low energy, and poor concentration. No history of high energy episodes. There is no history of mania, but there is depression. So it is a major depressive disorder, long depression plus no mania or hypomania. Question 2, a 24-year-old woman, a 24-year-old man has episodes of severe depression. Occasional periods of increased energy, confidence, decreased sleep lasting 4 to 5 days. So this is a typical case of mania. So there is no hospitalization, there is no psychosis. There is no hospitalization and no psychosis. We should think about a possibility of hypomania. There is increased energy, confidence, and decreased sleep lasting for 4 to 5 days. This is not lasting for greater than or equal to 1 week. So we need to think about hypomanic episode. So hypomanic episode in addition with depression, this can help us understand that it's a typical case of bipolar II disorder, hypomania plus depression. Question 3. A patient on fluoxetine is started on linezolid. So next day the patient develops fever, agitation, diarrhea, tremor, hyperreflexia. So one is an SSRI and there is another drug like linezolid. When an SSRI is given along with tramadol or linezolid, it can precipitate serotonin syndrome. So the pattern in this question is SSRI, drug interaction with linezolid, and hyperreflexia and clonus. Whenever you see hyperreflexia and clonus in a question, you need to think about serotonin syndrome. So, a bipolar patient on lithium presents with coarse tremor, confusion, ataxia, and creatinine is elevated. There is a derangement in kidney function. So, you need to think about lithium toxicity. So, this is a classic case of lithium toxicity. The next best step is to stop lithium. Question 5. A patient overdoses on amitriptyline, which is a tricyclic antidepressant. The most dangerous complication of amitriptyline is we have already discussed about it. It's cardiac toxicity, and we need to look for dangerous arrhythmias. Question 6. A 32-year-old man presents with severe agitation, grandiosity, no sleep for 4 days, aggressive behavior. Agitation, grandiosity, no sleep for 4 days, aggressive behavior. So all these outlines to a diagnosis of bipolar disorder. And the best treatment for mania and hypomania is antipsychotic along with a mood stabilizer. Antipsychotic alone shouldn't be given because it can trigger eventual mania. So now let's discuss a high yield table on uh, side effects, classic side effects of antidepressants. SSRIs cause sexual dysfunction, SNRIs cause hypertension, TCS cause arrhythmia and anticholinergic effects, MAOA inhibitors cause hypertensive crisis, bupropion causes seizures, and mirtazapine causes weight gain. Mood stabilizers. Lithium causes thyroid toxicity and kidney toxicity. Valproate causes hepatotoxicity and neural tube defects in pregnant women. Carbamazepine causes bone marrow toxicity, and lamotrigine causes skin toxicity, presenting as oral ulcers. Typically, it can be a case of Stevens-Johnson syndrome when there is lamotrigine toxicity. Common exam traps for us includes we might treat bipolar depression with SSRI alone because and then it can so we shouldn't miss history of hypomania. We shouldn't confuse serotonin syndrome with neuroleptic malignant syndrome. We shouldn't ignore lithium toxicity triggers like dehydration and NSAIDs. We should not forget that TCA eventually leads to cardiac toxicity and dangerous arrhythmias. So rapid diagnosis rules includes a depression only, MDD, mania, bipolar 1, hypomania plus depression, bipolar 2, chronic mild mood swings, chronic mood swings, cyclothymic disorder. Excuse me. Major depressive disorder, we need to think about using SSRIs as a first line drug. Bipolar disorder, we need to use a mood stabilizer along with an antipsychotic. Acute mania, we need to use an antipsychotic and a mood stabilizer. Suicidal patient, we need to hospitalize first, diagnose and treat later because safety is more important. Serotonin syndrome, we need to stop the drugs and provide supportive care. So safety always comes before diagnosis in psychiatric conditions. So we have already discussed these mnemonic for mania, distractibility, irresponsible behavior, grandiosity, flight of ideas, increased activity, decreased sleep, and talkativeness. So symptoms for depression includes sleep, loss of interest, guilt, low energy, poor concentration, appetite changes, psychomotor changes, and suicidal intent. Greater than or equal to 5 symptoms for greater than or equal to 2 weeks. Now we'll discuss few clinical pearls. So always ask depressed patients, have you ever had a period of abnormally high energy? We need to ask about any previous history of manic episodes because many bipolar patients has patients with depression. Now, coming to clinical pearl 2, we should never start antidepressants without screening for bipolar disorder because antidepressants, when given alone, can trigger mania, and they should only be given in bipolar disorder. They should only be given when they're already being given with a mood stabilizer too. So, step one focus points includes mania versus hypomania, bipolar versus depression, antidepressant side effects, lithium toxicity and monitoring, serotonin syndrome versus neuroleptic malignant syndrome, and suicide risk management. If drugs are mentioned, you need to look out for if the question is expecting a side effect. So, quick revision checklist. What type of mood episode is this? How long did the symptoms last? Any history of mania or hypomania? Which drug is the patient taking? Is this an emergency? Is Are there any suicidal intents seen in this patient? So, if you answer these, diagnosis becomes easy. Final summary: mood disorders are common and highly testable. Bipolar disorder is often missed. You shouldn't miss mania and hypomania episodes. Antidepressants can worsen bipolar disorder. Drug toxicities are high yield, pattern recognition solves, and it is a key for any psychiatric question. So, in the next video, the last part of our psychiatry series, we'll be discussing about anxiety disorders, obsessive compulsive disorders, personality disorders, sleep disorders, and we'll also be doing a rapid full system revision for step one, psychiatry. So this lecture series is free, structured, high yield medical education uh, related to USMLE Step 1 and NEET PG. Please subscribe for upcoming lecture series.